Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. I'm your host, Jacob Hutcherson. Today I'm delighted to be joined by Donna Nucci, a distinguished figure in the field of infection prevention. Donna brings a wealth of experience and expertise to the table, currently serving as Assistant Director of Infection Prevention at Yale New Haven Health System. In addition, she runs her own infection prevention consulting business, showcasing her dedication and commitment to the field. In this episode, we'll have the privilege of exploring Donna's extensive career as a registered nurse with a Master of Science degree and certification in infection prevention. Donna's expertise is unparalleled. Her entire career has been dedicated to infection prevention, with over a decade of experience primarily working within ambulatory programs. Join us as we delve into Donna's remarkable career trajectory, discuss her approach to infection prevention, and uncover the insights she's gained over the years in ensuring the highest standards of patient safety and care.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
I am the Director of Infection Prevention for Yale New Haven Health System, which is a 7-hospital system across 2 states. We border, our furthest hospital is on the New York border, and we have a hospital that's in Rhode Island. So although we, under Medicare license, do combine a few of the hospitals, they are unique in and of themselves and in their own buildings. So I oftentimes like to say it actually is 7 unique types of communities. And I think the persons that work in those hospitals would say the same thing. Like, we're not like the other hospital that's across the street. Many hospitals, I think, for a variety of reasons, are having to do that now to combine Medicare licenses. So that's what I do right now.
Interesting. Okay. All right. So you've been in the infection prevention arena since 2007, I believe. How did you discover that? And then what was your educational kind of background?
Sure. So I had been a bedside nurse at that point for many years, and I was working at Yale New Haven in the recovery room. And I had a mentor who really was like, I really feel like I would like to give you this responsibility to decrease surgical site infections and be our infection prevention liaison. What do you think? And I said, I'll give it a try, not really knowing what I was getting myself into. And shortly I did choose sort of a few other mentors that came in and helped me. I had a pharmacist who'd helped me, another couple nurses, but nobody actually in the real infection prevention department, which was interesting. I was sort of an aside because we had kind of a dotted line at the time. But then within 18 months, I became certified, CIC certified. I think sometimes you know when you know, sort of like falling in love. So all of a sudden I knew, and I had done a lot of types of nursing, from pediatric oncology to labor and birth. I was a lactation consultant. I'd done a lot of things in my career at that point. And I think I knew at that time I had 4 young kids, and it sort of fit in with my lifestyle, and I just had a passion for it. So I immediately took to it and decided to just try to find out everything I could possibly know about infection prevention.
Okay. So what were the incentives there? Obviously you said you'd done different things in nursing, and then, so was there just something about infections that interested you, or was there also like a financial incentive or a scheduling incentive, or like what was it that caused you to really take a harder look?
Yeah, definitely not financial, because there was no financial difference in what I was making. I think that I already had sort of a flexible job. I was one of those types of nurses that said, I'm never getting away from the bedside. I love the bedside. I love patients. I'm never going to do anything different. I loved being in the operating room. And then for some reason, this other part of it, I think it was just a passion for, I always liked math. I always liked epidemiology. I always liked looking at things across sort of with a larger lens. And that's really what infection prevention was. So it allowed me to sort of maybe find this outlet I didn't really realize I had. that part where you're really analyzing things from a much higher level, but looking at numbers. I don't know. I just found it fascinating. So I don't think that there were any other things. I think nowadays we do see that. So now we see it's a better schedule. I don't want to be working weekends and holidays, but for me, it wasn't that.
Gotcha. Okay. So then, okay, when you made the transition, was it like you quit your old nursing job and you started an infection prevention job, or were you like doing a handful of hours a week just to kind of like get your feet wet and see if it's something you're interested in? Or what was that transition like till you made like the full swap?
Yep. I had a very unique transition. So I did work both for a little while, and I was able to do infection prevention part-time. But then there came a time where that wasn't going to be, able to happen any longer. So I was actually at a system meeting where they were talking about infection prevention, and the then medical director at the time didn't know that nobody had told me that I was going to be coming into the infection prevention department officially. And he made the announcement. And he said, well, I'd really like to welcome Donna Nucci. She'll be joining the infection prevention department on Monday. And I was like, I am? I had no idea. So, this was quite a while ago where there were very different sort of HR practices, and it was fine. It wasn't not what I didn't want, but I didn't know. So at that point, I ended up sort of being able to make my own role. I think 15 years ago, infection prevention was very different. So it was like, what part of the hospital would you like to sort of be in charge of? And for me, it was ambulatory, all the ambulatory surgery centers, pharmacies, cancer care. Yale-New Haven's a big organization. So we developed that ambulatory program with really, I think I had a really amazing amount of women leaders within the organization that were helping me and driving me into how to organize everything, how to do what I was doing. It's a very nurturing organization. So I think I learned a lot. People were very kind to me as I was trying to navigate my way through what I should do. And then I ended up doing that for about 10 years.
Gotcha. Okay. So then did you pick the ambulatory side? Was that just like the biggest need in the opening they had?
Yes.
Or did you have a particular interest? Okay. So that was the
need. That was right then. That was the need. And that was sort of what the hot topic was back then. No one had been looking at ambulatory. Right. So, and I came from ambulatory. I had worked at this ambulatory surgery center for Yale that Yale had sort of acquired. And then it just kind of came about that way. And then through the national organization, I think APIC, that had become a very big hot topic. Like, what is the organization doing about ambulatory? So I traveled all around the state to every ambulatory center for many years to make sure that they were following infection prevention practices, and then working with the main hospital department on policies and making sure that we were making policies that made sense in the ambulatory sector as well. Because if you get admitted to an ICU, it's very different than you coming in to see your doctor for a well visit. And so we had to make sure policies addressed both things. And even today we do that. Today we even look at, what makes sense in an acute care hospital setting and what makes sense when I'm coming in to get my vaccinations.
Okay. So were you the one that essentially started the infection prevention program at all these ambulatory centers, or a lot of them?
I was probably the first one that was the touch point for the organization. So it was the first time I think that the organization had said, we really need to make sure that our ambulatory sector, which was growing back then, and it's still growing, but I think back then we were really starting, it was sort of the cusp of when hospitals started to look at their footprint outside of the main acute care hospital. So we developed, and I was able to get published on a risk assessment that we did. So we were able to look at, I think when I started, we only had 50 ambulatory sites, and it's grown to well over 100, into the hundreds of ambulatory sites now. Wow. And we started to do higher level things in ambulatory. So now most big healthcare systems have pharmacies that are off-site. That never would have happened before. So now we're compounding medications. They are doing very high level things in cancer care centers. So patients are getting radiation, they're getting procedures. You're actually doing some total hip, total joints in ambulatory now. So things were rapidly changing over those 10 years, where ambulatory was becoming the hot spot. And it was where the Joint Commission and other regulatory bodies were starting to say, hey, are you making sure that what's happening to a patient when they walk through your door safe, that they're just as safe when they walk through to have their blood drawn? So I did a lot of work on all those areas to make sure safe injection practices, hand hygiene, wearing the proper PPE were being done in the ambulatory sector. Absolutely loved it, and took, more, I don't want to make it like it wasn't male mentors, because I certainly had some of those as well. But absolutely, somebody drew me into the inpatient side and said, you've been doing this a long time, and we'd really, really need your expertise at this one particular delivery network for Yale New Haven. And we would love if you would consider doing the acute care side. And I ended up saying yes, and then loving that for 4 years.
Gotcha. Okay. So then the ambulatory, the focus then, is it similar to how like long-term care nursing homes tend to be the focus now? Is that a very similar environment?
I think it's probably very similar, because now you see the CDC really talking about long-term care, because during COVID, we saw a lot of patients, right? And I think now, like on the acute care side, we're looking at long-term cares and saying multiple drug resistant organisms and other sort of patient safety, antibiotic stewardship and other things. What's happening in long-term care? And I think you're going to see a tremendous amount of oversight moving forward in long-term care. I think we're going to see a lot more reporting and mandatory reporting. So I think absolutely COVID changed the landscape for long-term care.
Right. Okay. So sticking with that kind of initial transition into infection prevention, obviously you didn't really know what you were getting yourself into early on. You made the full swap though later on into the department. Was there anything as far as your like day-to-day that really surprised you, or that was just very different from your previous work, just doing random nursing?
I think the thing that I was the most surprised about is that it's still different every single day. So what I loved about nursing, and I always chose parts of nursing where you didn't have patients for a long period of time. So the patient was admitted, had their baby and left. Pediatrics was a little different, where you would take care of patients for a longer period of time, but even surgery. And so for me, and I think also that I'm learning something new every day. So I could take a webinar every day and still not know everything about infection prevention. And then there's also usually new and novel things happening. I think anything you read in the news where you're reading about that there's an outbreak someplace, or that there is a new organism that we've discovered, that really is something that every day I'm having to learn something new about that. And then I think also the people skills. I don't think I realized how much the people skills were going to be needed, and soft skills surrounding getting buy-in and kind of talking to frontline staff members and educating them about infection prevention. They usually have sometimes a very strong questioning attitude. So it was about having to really become a subject expert about a lot of different things. And that can take quite a while and become intimidating. So that's, cool. I think it was different.
No, that's great.
Yeah.
And then the other piece that I wanted to ask, I want to kind of hone in on this ambulatory versus short-term acute care piece. When you were kind of outside of the infection prevention department, but working in infection prevention, were you in the hospital at that point, or were you still in ambulatory?
So I was still in ambulatory. I did ambulatory for the first 10 years. And now I've moved to... So there was no transition.
Okay. So there was no transition when you were named part of the department. You had been
I stayed ambulatory for a while longer. Okay. Yeah. And then after a while, again, I never was seeking, I think, their promotion. Once you're in something for long enough, and I think you become experienced enough, if you have a really good and solid employer who is looking to groom people and make them stay within the organization, then you will get those opportunities. So I feel very lucky that I have been working for an organization that has provided me with the opportunities for advancement. I did go back and get my master's degree, kind of knowing that I might eventually want to go into a higher level management degree. Typically, that's not something that's needed in nursing, and not in every organization, but in mine it is. So I ended up getting a healthcare management degree. But again, I think, as I've indicated, would call myself a lifelong learner. So I think that's what I love about the job, is that I'm learning something new every day. Nothing is the same.
Yeah, that's great. So let's see. One thing that's rare when I'm looking at, and you've got some other things that we'll talk about, but what's pretty unique about your career path in infection is you've continued to grow within your own, like with the same facility. You see it typically, if you want to advance quickly in infection prevention, you're having to move around, just based on the size of the facility, the needs. I mean, it's just kind of a reality of this career, but somehow you've managed to be with the large, good health system from the beginning and just work your way up. So I want to talk a little bit about that kind of progression within the same facility. So you said you spent the first, 8 years or so in ambulatory?
Yes.
So then you eventually got promoted to manager. When you got promoted, is that when you moved to short-term acute care, or did you do a little of it before the manager title came along?
No, before the manager title. I mean, I did in that I was a subject expert for the department.
Okay.
So working with the team and understanding all of that, but then and understanding what infection prevention was on the acute care side. So, but I definitely jumped from ambulatory manager, developer of an entire ambulatory program to manager of a hospital that I actually, all four of my children were born there. I had come from there, so it's like near my home. I had worked there in labor and birth for 10 years prior to coming into infection prevention. So when the opportunity came up to go into this hospital and really someplace I felt very much was like home, I jumped at it. And again, though, I say it that way, like I jumped at it. It was definitely through, again, female leaders in my department saying to me, this is an opportunity, and this is an opportunity where you can change lives. And then I do feel like I went in and I do feel like it was an opportunity to work with a group of people in a smaller setting. So again, I say 7 hospitals, right? Different organizations, very different cultures everywhere. This was one where I at least knew some of it before I then now have since moved into the director position
Gotcha.
just about a year and a half ago. And I loved being the manager of the smaller delivery network. But I think to your point, if you don't work for a big hospital system, and I have a lot of peer directors that I talk to, and everybody's very generous in sharing like what does their organization do, what does their structure look like, because there's so much in data analytics. Infection prevention, sometimes it's an infection preventionist who's doing a traditional infection prevention role. And then I like to hire infection preventionists that also maybe really like the data part of it, or really like the lab part of it and the microorganism part of it. So I think infection prevention is changing in that there could be a lot of things that you love. And maybe like now we did an internship program at Yale where we are exploring having persons who are getting a degree, master's degree in public health. What does that look like if you want to come into an acute care hospital and work in infection prevention? So I think it's a evolving landscape for infection preventionists. And even I think hospitals are starting to buy VNAs and starting to get into long-term care business. So as that changes, right, I think that you're going to see a lot of variety in what infection preventionists do.
Gotcha. Okay, so you take a step back here, and I do want to hit on some of the things that you mentioned there. So you jumped from ambulatory by yourself, establishing programs over, I mean, I don't know how close, I don't know if it was over 100 facilities at that time, but it was it was growing for sure. So then you moved over to be manager, short-term acute care. I assume you had a department reporting to you at this point?
Yeah. So, well, it's a hospital. It's a 400-bed hospital with ICUs and operating rooms and everything. So it's a hospital that became part of our health system, and affiliated with that hospital is also 25 ambulatory sites, but very much systemized. So lots of organizations want to have we have what we call like a care signature model. So no matter where you walk in, you're getting the same quality of care. So this particular delivery network was somewhat new, and there was an opportunity for an infection preventionist. And so I just ended up taking it. So I went into acute care and stayed there for 4 years and then moved into the director role. It is sort of a swerve, right, left, right.
Yeah.
But for me, it really worked well.
So, and just to be clear, in that manager role that you had for the 4 years, did you have any IP staff people reporting to you?
Yes.
Okay.
Yep.
What was your team?
So it's a 2-hospital system. So it's 1 hospital in Rhode Island with an infection preventionist, 1 infection preventionist under at the other hospital, and then an administrative help. But when you're part of a large hospital system, then I also had data analytics people that were system people that helped us with our data analytics. Excellent. So although not direct reports, have like a dotted line and would be assigned to my hospital to do some of my data analytics and chart review and surveillance.
Excellent. Okay. So then was that your first position managing a team?
Yes.
Okay.
Yes.
So talk to me about that. Was that a big change? Was that something, obviously you had a lot of experience here, so I'm sure you're comfortable working with people and whatnot, but was there any surprises on that point, or did that just kind of come naturally?
Yeah, a little bit maybe, but I think I had worked in the industry for so long, and even having worked in leadership positions in nursing in the past, that it wasn't that big of a change for me.
Okay.
If anything, the biggest change is realizing um, creating change in any organization is a challenge when you have to implement things and get buy-in from thousands of staff members.
Right.
So I think that was the bigger challenge than managing people, because the people that my experience anyways in the years I've been in management, which now has been upwards of 7 years, is that I've been working with teams that I feel like are just not difficult. And I know other people would say different, but I in particular have been very lucky to people that have a passion for the job and have a passion for understanding and want to be part of a team, want to help each other. So I have people who work at one hospital in one state, but will work for hours with a person, all the way at the other end of another state to try to help them to figure out a problem. Excellent. So we're very much sometimes detectives, and we have a morning huddle every morning for 50 minutes. And I have people all the time say, well, you know what, can you stay on? Because I'm going to help you with that problem. So I've been very, very lucky and fortunate to work with teams. I'm not trying to make it sound all rosy, because obviously there's a lot of team building that goes on with that and other things that you do.
Of course.
And meetings that you have to plan. But for the most part, I will say that infection preventionists have such a curious nature and helpful, that they, you don't go into it to work in a silo. You go into it because you're going to have to engage with a lot of people for a variety of reasons.
Very cool. And then speak to okay, so I'm kind of in this weird, it's not weird. I'm just in a position where I hear from hospitals all the time. Hiring managers also hear from candidates making their case for jobs. So this has changed because I think there's some regulatory things that have changed and whatnot. But for a while, anyone in acute care, at least if they were using a recruiting firm, they would not entertain anybody out of ambulatory. It's like, nope, we need short-term acute care experience. So, and when you made this kind of transition, this was about that same time. So from your perspective, coming from ambulatory, jumping into short-term acute care, was it really that big of a difference? And then if you were speaking to somebody in an ambulatory unit, I guess what would you tell them is very similar and then very different?
So I actually just had someone in our division move to the inpatient sector, acute care, from ambulatory. I think the very basics of infection prevention are the same. So there's very basic things that every infection preventionist has to know and understands, whether you're in ambulatory, whether you're in long-term care, no matter where you work in infection prevention, there are basics. And when you become CIC certified, which is what really people should be looking at, you have a very high level amount of knowledge about infection prevention. So CIC certification for me is always the first. If I'm hiring someone, I want to hire somebody that's CIC certified. If I can't find somebody that's CIC certified, because I know that person has a very high level knowledge of infection prevention. You have to work in infection prevention for over, I think now it's 1.5 years before you can take the test. It's an extremely difficult test. There's lots of studying that has to happen and lots of experience you have to have. So in my mind, it's not where they've worked, it's that they're CIC certified. And if they're coming to me CIC certified, I can always get them up to speed on the surveillance part of it. So acute care, the difference is that you are now responsible for mandatory reporting to the government. That's really the very, and you might encounter different unique circumstances, outbreaks on units, different organisms, but that's what infection preventionists do. So if you understand the basics of microbiology and you can pass the CIC exam and you know why people need to be put on precautions, you can understand Candida auris. I mean, it's just that's not a huge leap because we're always learning. So I'm surprised because I think that if you're trying to find somebody to be in infection prevention for your organization, I did some work from APIC in West Virginia, very rural hospitals where they really had a hard time finding infection preventionists. Is if you can find somebody with any experience in infection prevention, I don't think the jump to acute care is that difficult. It's just understanding the definitions of surveillance. And the CDC, NHSN has copious amounts of education surrounding that to help you understand what you have to report to the government, what the measures are, what you might get a penalty about. So I think that's probably going to change as a lot of infection preventionists retire in the coming years. And maybe you'll see that change a little bit where people will be more willing to take somebody from ambulatory.
Yeah, it's definitely changed in the last 5 years or so. So
Mm-hmm.
that doesn't surprise. It will not surprise me if it continues that way.
Yep.
But I know back 2016, 2017, there was some pretty significant hesitation. And some of that was from HR just not knowing what they were doing, but some of it wasn't. So I just wanted to know how realistic that gap or that learning gap was. So awesome. Okay, so you jumped into management. You're managing people, a couple of hospitals, some indirect reports, some regular reports. Then you ended up getting promoted again to the director role. Did that put you over more hospitals and people, or was that just a title change? Okay.
No,
so what was that?
So then now you're in charge of the 7 hospital system, which is like 5 in sort of CMS terms, and a much wider span. So each hospital has its own infection preventionist, and then some of those hospitals have teams. So some of my hospitals have 3 or 4 infection preventionists, and our main flagship, the sort of largest hospital, has 8. And then there's an ambulatory sector now of 3 people that were doing the job I was doing as one person. And I say that with tongue in cheek because it's totally not that, I was doing the work of 3 people at all. It's just that a lot has changed now.
Right.
And the way that we do things changed. So, so it's a much bigger job, and a bigger job in that executive report out up. So, and then data analytics people as well. Yeah. And I love it. I absolutely love it. Yeah.
That's awesome. That's awesome. So when you're getting these promotions internally, was this just something to where there was an opening and you applied, or was this something you were kind of putting in the back of somebody's ear? Like, hey, I'm really looking to grow. Like, keep me in mind.
This was a surprise retirement. So somebody decided to retire, during COVID, and the opportunity came up. I gave it a lot of thought because I do consult also. Mm-hmm. And I have always consulted for over 10 years, and very much supported by my organization. I've always done helping surgery centers and other organizations, sort of a lot of writing and just fun stuff for me of helping people with low resourced organizations to build an infection prevention program that keeps patients safer, which is what we all want, right? And so I went back and forth. It happened that in my life was changing, that my children were leaving for college, and I had completed my master's degree, years before, but not that many years before. I, about to be 2 college graduates when I decided to take the director job. And so I think everything happens for a reason, for some reason. And it came up. I soul searched for a while. Again, had another amazing mentor who has since left the organization that was like, this is something I really feel like is a calling for you, and you should consider applying. I didn't apply at first. And then I did decide eventually to apply. And then I did have an amazing, at that time, VP2 who really pushed me. And he was, advocated for the role and for making sure there was a considerable amount of compensation difference. I just got very lucky. I really did. I just really got lucky with people who throughout the years have always been very confident in me and sort of been mentors. I ended up talking to at least 4 or 5 people who I considered mentors in the organization. People were very high level at my own small hospital and otherwise, because now I've been here a long time. Mm-hmm. And people were very generous with their time about, like, why wouldn't you do this? This could really change the lives of patients. So
that's great. And one thing, my question now, because you're over a bunch of hospitals, a bunch of people in like a pretty notorious academic health mm-hmm. system. What's next? And I don't mean that like personally, like I'm not trying to encourage you.
I'll answer all that.
But my question though, like, and I'm asking everybody at this level, and I've gotten some very different answers. So like, you're pretty well maxed out here in terms mm-hmm. of infection prevention growth. So what I've seen people do, you have the option of finding somewhere that has a few more hospitals or a few more beds, maybe a few more patient populations.
Yeah, that's not going to happen where I am, right?
But that's an option. But it's a pretty limited option because there's only a handful of health systems that mm-hmm. are going to be this large. Then the other thing I've seen is people adding patient safety, accreditation,
Mhm.
quality, some additional thing.
Yep.
But
Occupational health.
what
Yep.
I've learned is typically that means about $5,000 to $10,000 more a year, and you
Yep.
just added another full-time job to your plate. So that doesn't
Right.
seem like the best or the most
Right.
interesting route to take. And then the other thing that I've seen, like, I don't know, most infection prevention professionals report up to quality. Not sure if that's the case here, but that
Yep.
kind of
It
typically
is.
is how it goes. So like in my mind, it's like, okay, well, the next step is quality, but talking to more and more infection people, that's not really the most natural progression.
Right.
So for you, what does that mean? Because if there's one thing that's been consistent that I've learned from infection prevention people is everybody loves to learn. They're continually challenging themselves and learning more. So how do you do that now when you're pretty well maxed out as far as like career growth within Yale?
Right.
So what does that look like for you? How are you
Yeah.
continually learning and challenging yourself?
I think there's two things that can happen. You can go into a global healthcare. So you could decide to go work for like the European CDC or our CDC. Again, probably with those types of jobs, you're not going to make more money and you're probably not going to be higher up, right? So it kind of depends on, I had always thought maybe I would go the chief nursing officer, route. I looked at getting my PhD. Maybe that would like sort of poise me for that. I think depending on your age. So if you're, at my position as a director, which many directors are in their late 30s and 40s, you're thinking like, I can't max out at this, right? So I think depending on where you are in your career and your age is going to be a big factor. I do think there's going to be a tremendous need for infection preventionists in other industries. So industries like AI and machine learning and like, what is infection prevention? What does this mean? Where's the technology for infection prevention going? And there could be roles and jobs for infection prevention as consultants to other organizations. So less traditional, probably more money is what I'm thinking. So I'm thinking that as infection prevention technology changes, we will see infection preventionists go into other sectors. Just like we saw nurses, a nurse was a nurse as a nurse. And now you see nurses doing a variety of things in their career, right? They can be any number of things. And so I work with nurses in my organization that are VPs of something that isn't, it is related to healthcare, but their background was nursing, and they're the COO of a hospital. So I think that we're going to see infection preventionists go into maybe more global healthcare. It's not going to be a traditional, I think if you're looking for hospitals to promote an infection preventionist or create a role in infection preventionist that gets to that VP level, that's tricky. And I can't envision that being something that would be financially sustainable for any hospital system.
Gotcha.
So, yeah.
That's a good answer. And then you mentioned it a couple of times now, like you've done a lot of consulting. I've noticed you've got some publications and you're kind of involved in the academic side. So where does that fit in? When did that start to become something you wanted to add to your plate? And then what benefit have you seen from that?
Yeah. So I added it because I met a pharmacist who's now close to retiring, but 10 or plus years ago, in the state of Connecticut, New Jersey, a bunch of other states, you have to have a pharmacy consultant. So you have to have a pharmacist come in and make sure that you have safe medication practices, and they have to come in quarterly, and you pay that pharmacist for those services. And it can be upwards of $5,000 to $10,000 a year. He was seeing a lot of centers fail their infection prevention survey, and he was also seeing a lot of organizations just have really bad practices. He would go in and they would say like, "Oh, we had 5 people get an infection last month, and we don't know why." And so he queried me about whether or not I'd be interested in consulting for some of those centers. And then my national organization has some consulting as well. And they sort of asked me whether or not I'd like to consult for them. I have done some sort of, publications and other things where people sort of just asked me to speak as a subject expert at like national conferences and so forth. And so for me, it was about, I think it goes back to the nursing, but more or less of my sort of like ethics of every patient should get the same care no matter where they go. And so it feeds my soul in a different way where now with staff turnover and post-COVID, surgery centers are really struggling. You cannot keep people. There's always new staff coming in. And so how does somebody who comes in as a new chief nursing officer or and she's all of a sudden also the infection preventionist for the center. And I have some bigger organizations as well that I consult for, big national organizations. And they don't need somebody on site full time, but they need a set of tools. And so it's about creating a set of tools or reviewing things for them. Very much like the infrastructure was there. I did work part-time for quite some time when I first started out. So I was able to sort of like build a platform and build a website and, hire some support staff that kind of helped me with that part of it. But for me, I think it was just really important to be able to have a resource so that where somebody could call and say, like, I have this problem or I have this issue. What do you think? So
Gotcha.
like just recently I had somebody who had an outbreak of infections, serious infections, and then a survey, and they're not going to be able to open back up unless they can find an infection preventionist. So how do you say no to that? And that's mostly how most of my clients have come to me is organizations that have some pretty egregious practices, some really big patient safety issues, and they really need help.
Yeah. Makes sense. I know the feeling there. That's the folks that calling us as well. So that's good. So most of the other folks that I've talked to, there's been a big emphasis on networking, going to National APIC, involving yourself. I'm curious how important you see that being. Like, where does that come into play in all of this, particularly being somebody that stayed at the same place for all of their infection prevention career. So would you hold that as valuable as others? And I just want to hear your perspective on some of the national events and the networking piece of that.
Yeah, I think it's important. I mean, I try to send as many of my staff members as possible. And I've lost three or four staff members even since I've started to go on to other jobs or moving or, I'm happy for them. I think it's not everybody's journey to stay with one organization. I happen to just from location sense, I'm not moving or going anywhere. My husband has a business in Connecticut, so I'm not moving. But now with remote work, right, that's very different. And I do think that going to National APIC is important to not only network with vendors who might have opportunities for you. You might meet another infection preventionist from another part of the country. And now with more remote work, I get the question all the time. People say like, well, I want to work remotely. Right now, I don't have that in my repertoire, but only because I can hire people that are close by. But I think if I was in a smaller hospital, I would consider that. I would consider hiring somebody, to at least work somewhat remote who has a very high level of knowledge. So if you're an infection preventionist with my level of experience, or even 5, 6, 7, 8 years of experience going to National APIC and trying to find work in low resourced institutions, I think is very valuable. Even if your specialty is like, maybe you just have one specialty. Like for me, it's surgical site infections. I can cure your surgical site infection problem tomorrow if you, and I can do that remotely. So there's a very specific set of ways to reduce surgical site infections, and 99% of organizations aren't doing it. So there's a lot of people with lab, right? I have subject experts on my team that could be lab consultants remotely. I think that organizations, so by going to National APIC, you're networking, you're telling people about what you do. Maybe you're looking to, if you're willing to travel, you could be someplace for a few weeks out of the, and then be home for a couple of weeks. But I do think it's a great opportunity to network and find a job if you're looking to move.
Yeah. Okay. And then when it comes to hiring, I just want to hear your philosophy. Obviously you've got a large team underneath you. I imagine with the amount of turnover in infection prevention, you're probably hiring pretty consistently.
Yes.
What do you go for? There's different philosophies on this. Some it's not nearly as common anymore, but it used to be pretty prevalent to want nurses. You always prefer a nurse. If you can get a team full of nurses, that's ideal. Now it seems to be the prevailing thing to have the most diverse backgrounds as possible in the group. But I just want to hear your philosophy of like, if you could put an ideal team together, what kind of backgrounds would you like to pull together to make that?
So I don't know if I have a unique answer to this or what kind of answer it is, but for me, it isn't as much about knowledge because people who are in healthcare are usually pretty knowledgeable about healthcare. So sometimes it does come to a little different thing for me. I do think that we are going in the way of a lot of data and being able to put data together. So I'm looking for somebody usually who does definitely have a passion for patient safety and can speak to that professionally, who can go and talk to frontline teams in a professional manner and understand the challenges of frontline teams. So somebody maybe who isn't like completely rigid, like, well, it's black and white, right? You're supposed to do things this way, it's the one way. And that's one way to just have teams say, we're never having her come back or him come back and talk to our staff meeting again. Being able to understand the data. I usually can teach that. So usually if you don't know a lot about statistics, I can give you enough information. But if you're not even interested in math and statistics, that's a hard one. That's a hard one for me. I'm really looking for somebody who's going to be able to understand charts and graphs, presenting data, being able to put together a good PowerPoint presentation, able to present a good PowerPoint presentation. Yeah. So I feel like I love mentoring and I love onboarding new IPs. I've done a lot of that work. It's one of my favorite things to do, but it's getting somebody excited and passionate about the actual topic and the ability to actually communicate that. So I think for me, I'm looking for a good communicator more than I'm looking for with our background is. So if you come from the lab or you come from a public health degree or you came from working for a town health department, you're a nurse. I mean, you can have a nurse who has the inability to talk to others, but she's a nurse. So I'm not going to take a nurse over somebody who maybe is a new grad with a public health degree, but can put together a slide deck, an Excel, and is an amazing communicator. So I really look for a skill set that's going to be part of a bigger team.
No, that makes sense. Okay. Mm-hmm. But I want to talk about the internship program that you mentioned a few questions ago. And then you also talked about how much, like, your love for mentoring and onboarding new people. So I'm sure this kind of fits into that. But what have you, is this a program you put together or what is
No. So I have, I think we hired somebody who has a passion for mentoring, and he was able to sort of bring forward. APIC has a new framework. And again, it's about like interning. So I had done an intern last summer and he sort of transformed the program into a bigger program. And we did 3 interns this summer. So last summer, I was just really interested in bringing in an intern. I had an amazing experience. Somebody getting a public health degree who's actually a doctor in another country that was here. And she was amazing. It really worked out wonderful for me as far as understanding how to expose somebody to infection prevention. In a big academic institution like ours, it's pretty easy to get people a very good experience over 16 weeks. And this year, we just expanded it. More of my IPs in my under my purview kind of came on board and really helped with showing the interns, the nuts and bolts of infection prevention, what an infection preventionist does. I think we are getting more interest in that, having more people want to shadow in our department and so forth. And then they have a deliverable usually from their university. So they're usually in their final year of a public health degree. And then they come to us for an internship and they can get college credit. So usually it's 3 credits and they have a deliverable. We give them a project to do. That they, mine for my intern last year was hand hygiene. And this year they did another similar project. So for me, I think that really bringing on, if you're near a university as a infection preventionist, then offering that is a huge win. Yeah.
Is the internships, is that all on-site internships?
Mm-hmm. Yep. Okay. So they come on-site every day. Well, it's not every day, but schedule like a mutually amicable schedule with them.
Okay. Yeah. So it's a local university that would connect with you to do the internships. That's awesome.
Yes.
Yeah. I think the University of Michigan does something like that.
Yes. There's several hospitals around the country. I was shocked when I came into the director role that Yale wasn't doing this. And I think that, we have Yale School of Public Health. We have a lot of different public health universities in and around our area. So that, and then we also, once I started, I felt very passionate about bringing a high school volunteer into our department. So we also do that. So typically it used to be that we wouldn't, what's a high school grad, what's a high schooler going to do? But now we've been taking the high schoolers and having them come and giving them different duties, whether it be to go out on the floors and make sure the floors are clean, or go and check the hand hygiene dispensers, or to try to give exposure to high school students as well about what infection preventionists do.
Gotcha.
Yeah.
Gotcha. I want to ask about kind of budget, staffing, whatever. How do you, I guess, what's your financial argument for infection prevention to be valued and supported. Obviously, it's not like a revenue generating department. And in that case, it tends to be put on the back burner a lot of times as far as resources and support. How have you, or how do you go about making that case to kind of higher ups that may not quite understand the ins and outs of infection?
Yep. So I think that should be easy for everyone. If you're a hospital that accepts Medicare dollars, then you should be able to look at your hack penalties, your pay for performance, your star rating, all those measures. And we do analytics on that down to the dollar, like, how much money we're going to lose if we get XYZ number of infections. So that's a pretty easy one, because any hospital that's outside the scope of what they should be for hospital onset infections is going to get a penalty. And those parameters are just getting stricter and stricter. So just to give like a, example, if you're a small hospital in Texas and you have 300 beds, and Medicare says that you're only supposed to have one central line associated bloodstream infection and you have 3, and they say you're only supposed to have one catheter associated infection and you have 2, 1 MRSA, 3 C. diff, whatever they might say, and you are above that, you are going to end up with withholding of some of your Medicare dollars. Pay for performance, star rating. So all of that, I make a case for it. I have a whole slide deck that speaks to this so that people can understand that a lot of this is that. And then on the flip side of that is not tying it to money, right? Because there is always that financial incentive, but then there's also the incentive of course, ethics and patient safety. So any outcomes that we have in a patient that maybe were outside of what should have happened to that patient, we share a patient story at every meeting. So the beginning of the meeting, and if I'm presenting to an executive leadership team and I feel really strongly that we need another infection preventionist, or, I'm under-resourced because I have people out on medical leave or whatever it might be, I can speak to actually that actual patient, 50-year-old or, young woman came in and ended up coming in for just a regular surgery, ends up with a surgical site infection that ends up costing her life. Date of death is this date. And we as a hospital did this. XYZ patient's child came in, we gave them a central line. 3 weeks later, that baby died. So if you can make the case and actually put a name, I put names, faces, was a grandmother, those types of things. I think this might have been outside of what we should have done, because the definitions are the definitions. So it's not even sometimes that the hospital did something wrong and that we are able to prevent every infection, but there are specific definitions. And so every single infection we look at extremely closely. We look at what the patient demographics were. Is there something that we're doing for the social determinants of health? We really analyze everything. I am very lucky to work for an organization where I don't have to make any case for infection prevention, because we are a beloved department and people really see the value in it. I think COVID additionally made it even more. If anything, it's more frontline staff and maybe ancillary staff that have, and I think I put this in some of my notes for you, is now have a questioning attitude about anything to do with the government, right? Is that we're putting a mandate on them to wear gloves or a gown or to get a vaccine. And it's like Donna Nucci personally might be crazy, because that's like, fake science. So if anything, it's not so much the organization. The organizations I do work with at a national level that are not my employer, I do help them frame that through what should your infection prevention program look like based on what Medicare is telling us it should look like. And there are numerous studies to show how many infection preventionists can sort of tie into how many infections you might be preventing. So like you said, that's a difficult number. But when I'm helping other organizations with that, I find that most CEOs and CNOs and chief operating officers who work in healthcare want good patient outcomes. They'd be the head of a bank. So I don't usually have a hard time making that case, a financial case, and then sort of a moral, ethical case.
That's great. That's a great answer. Okay. Is there anything at all that you'd like to touch on or say, or advice you want to give?
I think that I do want to speak a little bit about infection preventionists and infection preventionists sort of breaking out into the consulting world, because there's not going to be enough infection preventionists. So we 100% know that it takes at least 2 to 3 years to get an infection preventionist educated, up to speed, and able to actually be a valuable resource to an organization, whether it be long-term care, ambulatory, acute care, no matter what it is, it's a good 3 years. No matter what your background is, there's just a lot of studying to do. So to your point on, now I've been an infection preventionist for 3 years. Now I've been an infection preventionist for 5 years, right? What does that look like? And if you're an organization that's saying, we've been talking to our recruiter for 6 months, 9 months, we cannot find the fit, right? We can't find somebody and we need somebody. I think that we're going to have to start to think more globally. So other organizations like Doctors Without Borders, or I was thinking of the big consulting companies who do a lot of performance improvement. I have kids now who work in this industry, right? So they're working for banks, big, large organizations, and consulting for them and telling them how to make sure they make money, how to make sure that their bank system doesn't go down from fraud, like all these other industries, right? In a healthcare industry, we are going to have to change how we look at how we work. So I think every infection preventionist, and I think that employers as well, are going to have to sort of think outside the box. Like, I'm willing to actually sit down and have somebody help me develop a program, have a liaison on site, maybe look at where my problem is, right? Do a full evaluation of the problem. Like, that's why somebody might hire an Accenture or a consulting company, right? So you're getting that infection preventionist, that knowledge. They're able to bring it in. They're able to do a full evaluation of what your program is. You're really, where did you lose your Medicare dollars? They can really come in. What are you doing to prevent all these different healthcare associated infections? Write up a report and then give you sort of a playbook and a tool book for how to prevent infections in the future. I think then you might, through that and through the passion that every infection preventionist have, be able to recruit from within. I think that's where organizations are sort of like, by not having somebody like you say, be more open book to, I can give you somebody, they can come and do this sort of like this. That might then also help them with whatever incentive. That person then can speak for that organization and say, like, I've been coming and they did everything I said. They instituted pre-op antibiotics. They instituted this and this. They were an easy organization to work for. Now you have somebody who's vouching for you as an organization. Maybe you're in a spot that nobody wants to move in the country, right? There's areas where you probably have no problem. Might not be Hawaii right now, but I was just thinking that as an example, right? I'm happy to move to Hawaii. It's a great place to live, right? There's all these top, New York City. Maybe it's easier to recruit into New York City than it is into El Paso, Texas. Is hospitals in small rural communities are going to have to be more open to having somebody evaluate everything. And then you would get, just like travel nursing, it's like travel. You're going to get somebody to say, like, I worked with this organization. They were great. You should consider working for them. I've already set up the whole program. It's not going to be overwhelming for you. Here it is, sort of, here's the package for you.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.